Greetings. My name is Greg DeFelice. I practice in New York City, and I'm currently the National Strategic Advisor for Miach Orthopaedics. I'd like to share with you how I incorporated the BEAR Biologic Implant into my practice. I've been practicing for 25 years, and for the past 20 years, my practice has centered around the concept of preservation first. It's a treatment algorithm based on tear type and tissue quality of the ACL. The basic concept is, why replace the ligament if it's simply detached? In other words, why do a reconstruction if you're facing an avulsion type injury? There are currently 4 lanes to my treatment highway, represented by the acronym REBAR. However, for many years there were 3: repair it if you can, repair and augment it if tissue is missing, and only reconstruct it as a last resort. Around 2.5 years ago, the BEAR implant added the biologic 4th lane to my treatment algorithm. Over these recent years, the BEAR implant has enabled me the confidence to repair mid-substance tears by biologically fortifying the healing environment in the knee after I repair the tissues. In 2025, I performed around 175 ligament surgeries. Of that group, I repaired 45%, I repaired with BEAR 25%, I repaired and augmented about 18%, and I only reconstructed 12%, including revisions. Now, we all know that interest in ACL primary repair has skyrocketed over the past decade, as detailed by this article in 2022. This literature has been dominated by 2 research groups, mine and the group led by Dr. Martha Murray, who invented the BEAR implant. And the articles keep coming. Many of you have heard of the BEAR. In a nutshell, it is a cylindrical sponge about the size of your thumb. It is made of decellularized type 1 bovine collagen. It holds the blood in the notch so it can act like a healing blanket for the ACL. It protects the clot from being washed away by synovial fluid or being enzymatically degraded, allowing biologic remodeling during the 8 weeks that it is present. The BEAR implant is approved for most age groups, complete or partial tears, and acute or chronic injuries. Most importantly, for the BEAR to work, the ACL remnant must be repairable and sufficient to hold sutures. Put it this way, if you don't do a sound repair of the tissues, the BEAR is not going to magically make things all better. Here is a schematic to show how the BEAR works. The sponge is soaked in whole blood and then placed on the ACL, which has been stitched together. This allows a durable clot to form surrounding the repaired ends of the ligament. Here you can see the hydrated implant and the disorganized type 3 collagen. With mechanical forces being applied and the clot protected by the BEAR, type 1 collagen begins to form and reconstitutes the native ACL tissue, as can be seen here. The BEAR implant's ability to restore the native ligament has been validated by clinical outcomes and histologic analysis. Also, with sequential MRI imaging through 2 years that demonstrates the healing process. We all know that ACL reconstruction, regardless of graft, has significant issues. We've been trying to optimize outcomes for the past 40 years, yet the same problems persist. The surgery is not benign, and regardless of graft choice or technique, complications are common, and the vexing problem of post-traumatic arthritis is alarmingly high. Going back to 2013, Murray and her team showed in a porcine model that the repair with BEAR approach resulted in significant reduction in post-traumatic arthritis. More recently, data from the BEAR 1 and 2 human clinical trials demonstrated that patients treated with the BEAR and repair approach had 6 times less post-traumatic arthritis than hamstring reconstruction patients at 6 years post-op. In addition, I recently presented my own clinical data at the ACL study group on a cohort treated with repair alone at 10 to 15-year follow-up that showed little to no post-traumatic arthritis. The BEAR implant is one of the most carefully studied devices in the ACL space. Since it was a de novo device rather than a 510(k), rigorous testing standards had to be met. The original 3 studies followed a strict and somewhat cumbersome technique protocol, whereas the post market bridge registry has allowed alternate techniques, including mine, to be used with very encouraging results. As I mentioned earlier, I added the BEAR to my preservation first algorithm to better address more complex tear patterns than simply type 1 avulsion type tears. This next case is that of a 17-year-old female soccer player who sustained a contact injury. Her physical exam with both the Lockman and the measurements with the lock meter were a bit limited due to splinting. After aspirating her bloody effusion, she quickly regained her motion. Unfortunately, her parents were familiar with the drill as her older sister had torn both knees playing college lacrosse and had graft augmentations for both. They were comfortable with my rebar approach. Her MRI's central slice, as seen here, suggests a non-repairable ACL tear. However, I always look inside the knee first to see what I truly have, and I strongly suggest that you do the same. Through the standard viewing portal, the ACL appears with the PL bundle detached and flipped forward. With a clamp, this was easily reduced, revealing a relatively normal AM bundle and a normal appearing ACL, far better than the MRI suggested. Holding the PL bundle reduced with a clamp and using a self-retrieving suture passer, I passed a cerclage stitch of O suture and then tied it with a knot pusher. This helps me to keep control of the ligament while I'm stitching it, as you'll see in a moment. A second stitch was placed but is not shown for time's sake. Once the ligament is under control, I then use the same self-retrieving suture passer to place a locking Benel type stitch of number 2 active braid into the AM bundle of the ACL. This suture is made of half collagen itself. As we move up the ligament, we pass from side to side with alternating half hitches to create an interlocking weave up the AM bundle of the ligament. For time's sake, we will fast forward. Once we get to the proximal aspect of the AM bundle, the sutures are exited on either side to facilitate anchoring. The same process is now repeated for the PL bundle. Once again, we're going to start as low on the bundle as we can, using the self-retrieving suture passer, this time with a striped active braid stitch to maintain organization. We go back and forth to gain good control of the PL bundle. However, this time, once we get to the proximal aspect of that bundle, we exit both limbs of the suture towards the wall to facilitate anchoring into the footprint. With the knee at 115 degrees of flexion, the PL anchor is punched, tapped, and placed. It is a 4.75 osseo suture anchor. The core stitches were then passed through the PL bundle for later use. With the knee at 90 degrees, the AM bundle anchor is now punched, tapped, and placed at the AM femoral origin using a second suture anchor, which also contains a 2.5 active braid tape for later use to anchor the BEAR. At this point, the ACL is nicely repaired and tensioned, and a standard ACL guide is used to introduce a cannulated drill up into the anterior third of the ligament. Through the cannulation, a nitinol passing wire is introduced. Now we'll move to the external view. Externally, the medial portal will be extended, so it's about 2 to 3 centimeters. This will allow the passage of the BEAR implant. If I can fit the tip of my finger into the portal, it's usually sufficient. Next, the joint is dried with a lap. This prevents the BEAR, being a sponge, from softening excessively. To prepare the implant, a hole is passed through the center. and a passing suture is then placed. This suture is used to deliver the active braid tapes from the AM anchor through the implant. Then, the earlier passing wire delivers these tapes down through the tibia, where it exits distally. Once this is accomplished, we are ready to hydrate the bear. The BEAR implant is then hydrated with 10 to 15 cc's of whole blood, first the sides and then the top. It's placed into the knee with a thumb push while the sutures are tensioned distally, orienting the implant anterior to and along the ACL as the knee is then extended. Once inside the knee, the bear goes to work, as we discussed earlier. The final part of the technique is to punch, tap, and place a third 4.75 osseo suture anchor into the anteromedial proximal tibia, which will both tension and secure the active braid tapes. One of the great benefits of not taking a graft is the rapid recovery. Here, the patient is seen performing weighted Bulgarian split squats at 10 weeks post-op. Preservation First and the rebar algorithm offer a pragmatic, sensible approach. Start small and only go big if needed. This means less morbidity, faster recovery, fewer complications, a more normal feeling knee, likely less post traumatic arthritis, and many other benefits. I'm not saying reconstruction should be abandoned. Some ligaments cannot be repaired. But I am saying look in the knee before you take the graft, and your mind may slowly change. I'll be here to teach you these techniques, as will the good people from Miach. Thank you kindly for your time and attention.